Hello everyone. Welcome to this second session. Uh, the chest X-ray and commonly seen abnormalities. The previous session was on normal chest X-ray, and during that session, I had tried to convey the importance of knowing how uh, normal chest X-ray looks like. This session will add on to the relevance of the previous session, and we will get a clear idea of knowing the relevance of normal chest X-ray. So let's continue. The commonly seen, we will be only discussing about the commonly seen abnormalities in a chest X-ray. And the abnormalities can be broadly divided as the abnormality seen in lung parenchyma, abnormality in pleura, abnormality in the hilum, abnormality in the mediastinum, abnormality in the diaphragm, and abnormality in chest wall and bones. So commonly seen abnormalities and very important abnormalities. I'll be only discussing about the very important ones. So we won't be touching every title given here. That is chest wall and bones and the diaphragm and even mediastinum. We will be focusing more on the very commonly seen abnormalities and the important ones, which you must really know about the importance of. So lung parenchymal diseases. Lung parenchymal disease. Okay, so the lung parenchymal diseases. The parenchymal diseases can be radiologically classified as either which show increased radiographic density or the ones which show decreased radiographic density. We know what radiographic density means. Radiographic density means something which appears whiter or opaque, more opaque. So the increased radiographic density seen can be further divided into something which affects predominantly the air space or something which affects the interstitial tissue. So we all know what the airspace implies, what the term airspace implies. The airspace means the alveoli and other spaces. We all know the tracheal tree, the subdivisions, and the respiratory bronchiole, terminal bronchiole, and which is further divided into the alveoli, which are the structural and the functional units of the lung. And then in between the alveoli, there is interstitial tissue. How does alveolar disease look like, and how does interstitial disease look like? See, these are the alveoli, the sac-like structures, and in alveolar disease, the air in the alveoli has been replaced by blood, pus, protein, or cell debris. Okay, so these are the alveoli. This is the inside, and usually air fills up the space, and in the in the in a pathology, the air in the alveoli, it will be replaced by blood, pus, water, protein or cell debris. And you can see the red lining here. This is the interstitial tissue. This is the interstitial tissue. Interstitial tissue. And interstitial disease, the scaffolding around the alveoli. This is the scaffolding around the alveoli is abnormal. Now, abnormal change can be due to edema, inflammation or fibrotic thickening. So, I hope it is clear on about the difference between the air space disease, that is the alveolar disease, and the interstitial disease. So, what are the features we have to look for in alveolar changes and interstitial changes? In alveolar changes, usual shadows will be fluffy or blobby, ill-defined, the margins will be ill-defined, they may be coalescing or merging, and they will be segmental or lobar. We know about the segments and the lobes of the lungs, I guess. We have an idea. Right lung is divided into 3 lobes, right, middle and lower lobe. And left lung is divided into 2 lobes, upper and lower. And the segments, these lobes are further divided into segments, which are 10 in the right and 9 in the left. Sometimes additionally we can see air bronchogram, which we will be discussing later in the session. The interstitial changes, what we have to look for, chest x-ray, there will be small nodules, linear or reticular opacities, linear or reticular opacity with septal line, reticulonodular, reduced lung volume, and honeycomb pattern may be seen additionally sometimes. And honeycomb pattern is seen at a very later stage or end stage of disease. Now we will be discussing about alveolar disease. Just like I told you, the air space is filled by blood, pus or mucus or water or protein or cell debris. And the alveoli in this case are stuffed with pus, giving a fluffy homogeneous pattern which has coalesced. See, now look at this X-ray. You can see a large patch or opacity. This is a homogeneous pattern, and it is a fluffy homogeneous pattern, which is a large one because of the coagulation of all the shadow which is caused by the pus filling the alveoli. You can see here. So you can make out the abnormality, and such a feature is seen in pneumonia where pus is being filled in the alveoli. You can see the classic alveolar pattern, fluffy shadowing. You can see the classic alveolar pattern, fluffy shadowing, which is seen in pneumonia over here. and you can see the difference. When there is interstitial fibrosis, there is no fluffy shadowing or patching. You can see this is the classic interstitial pattern, which is reticulonodular. This is the reticulonodular shadowing. So let's move on to the next topic. This is consolidation. Consolidation. What does the term consolidation mean? Something becoming something we are consolidating. This is becoming solid. That is becoming solid. So the alveolar space gets filled with the inflammatory exudate, and while the interstitium and architecture remain intact and the airway is patent. So this is how consolidation looks like on chest X-ray. There is opacity. Radiologically, what does consolidation transcribe into? Radiologically, it transcribes into a density corresponding a density. See, that's what I said. Density corresponding to a segment or lobe. Air bronchogram and no significant loss of lung volume. See, there is no significant loss of lung volume, and there is a density corresponding to a segment or lobe, and air bronchogram is C. What is air bronchogram sign? It is defined as visualization of bronchi within parenchymal consolidation, and findings: branching lucencies surrounded by consolidative opacity. See, the consolidation will be seen as an opacity, and there will be branching lucencies. So something black or dark seen, which is surrounded by white consolidative opacity. Differentials include non-obstructive atelectasis, pneumonia, pulmonary edema, hemorrhage, bronchoalveolar carcinoma, and lymphoma. So in these conditions, you can see air bronchogram sign. And what is the significance of air bronchogram sign? Okay, if the air bronchogram sign is present, you can exclude a pleural or mediastinal lesion. So this is the importance of air bronchogram sign, and these are the differentials, the conditions where air bronchogram sign is seen. So I think it is clear how air bronchogram sign looks like. If you can just observe here in this image, see, you can see a lucency, branching lucencies. See, this is branching. This is the lucency. You see, arrowhead is pointed to a lucency, and it is surrounded by opacity. So this is the air bronchogram sign, and if you see an air bronchogram sign on a chest X-ray, what are the differentials you should think about? These include non-obstructive atelectasis, pneumonia, pulmonary edema, hemorrhage, bronchoalveolar carcinoma, and lymphoma. So I hope air bronchogram sign is clear to you. Now we will talk about bulging fissure sign. Bulging fissure sign refers to lobar consolidation. This is a lobar consolidation where the affected portion of the lung is expanded. See, this is the bulging fissure sign, and you can see bulge. There is a bulge, and looks like a fissure. So this is how the term came. This is the bulging fissure sign. The most common infective causative agents are Klebsiella pneumonia, Streptococcus pneumonia, Pseudomonas aeruginosa, and Staph aureus. So these are the four organisms that cause bulging fissure sign, and the bulging fissure sign refers to lobar consolidation where the affected portion of the lung is expanded. Now let's come to Silhouette sign. Silhouette sign is a very important sign. It lets us come into a conclusion on what our diagnosis might be, or what we might be dealing with when we are looking at an abnormal chest X-ray. It kind of narrows down the differentials. See, just like when you see, aerogranulography is seen in a lot of conditions, right? Bulging fissure sign can be seen in a lot of infective pathology. So there are some abnormalities which show common features. So just to narrow down on or cut down on the different differentials, Silhouette sign may be important. So what is Silhouette sign? An intrathoracic radiopacity if in anatomic contact with the border of heart, aorta or diaphragm will obscure that border. So if there is an intrathoracic abnormality and if it is in contact with any of the borders of heart or contact with diaphragm or contact with aorta, it will obscure that border. That means the shape of that border will be changing. An intrathoracic lesion not anatomically continuous with a normal border or normal structure will not obliterate that border. So that's what a Silhouette sign means. So what is the Silhouette and what are the lung segments which are in a relationship with the Silhouette? So the anterior segment of right upper lung is related to superior vena cava or ascending aorta, and we know where to look for a ascending aorta or superior vena cava or an X-ray. So if there is a pathology involving anterior segment of right upper lobe, we have to look at the superior vena cava or ascending aorta and look whether it is obliterated or obscured. That's how we make up about a pathology in anterior segment of right upper lobe by looking at SVC or ascending aorta on a chest X-ray. The right atrium, medial segment of the right middle lobe. If there is a pathology in medial segment of right middle lobe, it will be evident by looking at the right atrium on a chest X-ray. Aortic arch, apical posterior segment of the left upper lobe, left ventricle, inferior lingular segment of the lung, right hemidiaphragm, you can see this is the right hemidiaphragm and this is the right lower lobe, and corresponding to left diaphragm and descending aorta will be dealing with a left lower lobe pathology. So this is very important. You take note of this table, and when you look at a chest X-ray, you can differentiate various pathologies in various segments of the lung by looking at these borders, or vice versa. If there is a right atrial pathology, it will be obscuring right lower lobe. Okay, so what is the application of Silhouette sign? Okay, example, in the case of cough and fever, and you can see the right mid-zone shadow and effacement of the heart border. You can see the effacement of the heart border and right mid-zone shadow. The frontal chest X-ray indicates middle lobe pneumonia. So this is where the importance of this lies. So I hope you get an idea. I am giving an example, the lateral view, and this is the lateral view. and it confirms the diagnosis. I hope it is clear. And let's say look at this example. Cough and fever. The left dome of diaphragm is ill-defined. See, this is the left of this is where the left dome of diaphragm should be, and it is ill-defined. You can see there is no clear division as you see on the right side. It is not very clearly defined, and so is the lateral margin of the descending aorta. These features indicate left lower lobe pneumonia. So this is typically seen in left lower lobe pneumonia. Following treatment, a repeat chest X-ray was obtained after 6 weeks, which shows that all of the normal sharp borders and margins have returned. You can see this is the diaphragm, and it looks sharp, and the margins have returned. So the pathology has disappeared. That's how the Silhouette sign is important. I hope it is clear. Now it is not just in pneumonia. See, the Silhouette sign is not just in pneumonia. I will give you an example. Middle-aged patient with a chronic cough. The chest X-ray shows an ill-defined left arm of diaphragm, but a normal left border of the heart. This is the left border of the heart. If you can appreciate, the arrows are showing, and I can draw for you the left border of the heart, which was clearly seen. And in addition, note the increased density projected over the left side of the heart. These features indicate pathology in the left lower lobe. The lateral view showed a lower lobe mass, a large lower lobe mass, bronchial carcinoma. So this is the picture of bronchial carcinoma, and this is how it looks like, and it is showing a Silhouette sign. So Silhouette sign is not seen just in pneumonia. It can also be seen in very different pathologies like bronchial carcinoma. I hope it is clear to you. Another example of Silhouette sign, see, and a mass lesion overlies the right hilum. This is the right hilum, and it overlies the right hilum. The right border of the heart is obliterated. You can see the right border of the heart is obliterated. You cannot make it out clearly. It is not sharply defined. Okay, so note that the right dome of the diaphragm remains well defined. See, this is the right diaphragm, and it looks well defined. And these findings indicate the lesion is intimately related to which lobe, lobe? I think it should be middle lobe, right middle lobe. And you just go through that table once again. Keep note of it, and that was very important. And I hope you understand. My job is just to teach you the significance of cardiac Silhouette and the different borders, so that when you see a chest X-ray individually, you can make out which lobe of the lung has a problem. Indicate the lesion is embedded in the margin of the heart. This was a benign mass. So in this case, it was a benign mass, a pericardial cyst. What are the pitfalls of cardiac Silhouette? In a small percentage of normal individual, the right heart border may not be seen. Okay, so we may misunderstand it, mistake it for some pathology, but it is a normal variant, not a normal variant. It's in normal people, some of the normal people, and the right order border is already not seen. So don't misunderstand it as some pathology. A depressed sternum can produce loss of the right hand border, an appearance which mimics middle lobe pneumonia. So the depressed sternum. So clinically, if you know the patient has a depressed sternum, on an X-ray, it can produce a loss of right hand border, an appearance which mimics middle lobe pneumonia. So we may start thinking about middle lobe pneumonia in that patient, but the patient has no pneumonia. So a depressed sternum, you should have it in mind that it may cause the loss of right heart border. This is because the depressed sternum pushes the right heart posteriorly and to the left. Okay, the sternum which gets depressed pushes the heart posteriorly and to the left. So right heart border is lost. Bunching of the soft tissue of the deformed chest wall causes an increase in density. Okay. Pitfall. The indistinct right hard border and the right mid-zone shadowing are caused by a depressed sternum. In this case, there is a depressed sternum. The indistinct right hard border, the right hard border is not distinct, and the right mid-zone shadowing. See, this is the right mid-zone shadowing, and there is the right hard border is not clearly visualized. The blurred area in the right hard border, see, is caused by adjacent epicardial fat. See, adjacent epicardial fat gives it a blurred area on the right hard border. So, till now you're talking about the presence of silhouette sign and its importance. It is not just the presence which is important, even the absence of silhouette sign is important. The absence of silhouette sign can tell you where a shadow is not situated, or consolidation or mass is not situated. So, example, if the right hand border is normal or there is no cardiac silhouette sign, there is no consolidation or mass in the right middle lobe. So that's the significance of silhouette sign. I hope it is clear. Now we will be discussing about collapse. In collapse, air is absorbed and not replaced, in contrast to consolidation. Okay, there are the signs of lobar or pulmonary collapse can be divided into direct or indirect. Collapse direct signs are opacity of the affected lobes, crowding of the vessels and bronchi within the collapsed area, displacement or bowing of the fissures. These are the direct signs. And indirect signs include compensatory hyperinflation of the normal lung, displacement of mediastinal structures towards the affected side. So if there is a collapse, there will be a loss of lung volume, and it will pull the trachea and the mediastinal structure towards the side of the collapse. That is ipsilateral shift of trachea and mediastinum. So if there is ipsilateral shift of trachea and mediastinum, collapse should definitely go through your mind in making a diagnosis. So displacement of ipsilateral hilum which changes shape, elevation of the ipsilateral hemidiaphragm. See, that's what I said. Just go with the basic concept that if there is a loss of lung volume, it will pull structures towards itself. So mediastinum is pulled towards that side, trachea is pulled to that side, and even ipsilateral diaphragm is pulled to that side, and crowding of the ribs on the affected side is seen. These are the indirect signs. And displacement of ipsilateral hilum which changes shape. Okay, the ipsilateral hilum will also be displaced. Elevation of the ipsilateral hemidiaphragm, I said again, and crowding of the ribs on the affected side. So the radiographic features seen in collapse. This is the golden S sign. Remember, keep it in your mind. This is golden S sign. So this is the arrow, and this is the golden S sign. You can see an S-shaped sign, and that is golden S signs in case of collapse due to a hilar mass. This is the hilar mass. This is the hilar mass, and this is the S sign. The mass gives a convexity. See, this is the convexity given by the mass. Mass gives it a convexity to the concave displaced fissure, and the fissure is displaced, and thus an S-shaped S shape is given, that is known as the golden S sign. Left lung collapse, ipsilateral shift of trachea, just like we said. See, this is the trachea. If you can appreciate, this is the trachea, and it is shifted to the left or to the side, ipsilateral side. I have already told you why, because of the loss of volume. Bronchial cutoff sign, the bronchial cutoff sign or left main stem bronchus. Look at the left main stem bronchus, that is the bronchial cutoff sign. Crowding of ribs is seen here. See, if you compare with the other side, there is a definite crowding of ribs on the left side, and loss of volume, and compensatory inflation or hyperinflation of the right leg. See, due to the collapse on the left, there is a compensatory circulation of the left lung. Now let's go to the differences between collapse and consolidation, the two topics which we discussed. There is volume loss in collapse. There is no volume loss. In fact, it is either normal or increased. Associated ipsilateral shift, there is no shift, or if at all present, it will be contralateral shift of the trachea and mediastinal structures. There is a linear wedge-shaped consolidation of airspace process, and it is an airspace process. Apex at hilum, not centered at hilum in consolidation, and air bronchograms are not seen in collapse, and air bronchograms are seen in consolidation. Now let's discuss about interstitial disease. I don't want to discuss much about interstitial disease with you people. Interstitial disease, the interstitium is fibrotic and thickened. Example, sarcoidosis. Okay, interstitium is fibrotic and thickened, and it is seen in sarcoidosis. Diffuse lung disease, non-homogeneous. Various patterns are linear septal lines, miliary shadow, reticulonodular, honeycombing, cystic, peribronchial cuffing. What are Curley lines? Curley lines are very important. Curley's A lines, Curley's B lines, and Curley's C lines. You should keep these in mind. Curley's lines are very important. At least you should know there are three lines, and I think A and B are very important. I'll show you the lines. Let's describe. Let me describe linear opacities. These are linear opacities extending from the periphery to the hilar. These linear opacities are known as, see, if you can appreciate in this image, see, both sides it is shown by white arrows. These are the curly lines, and you can see even on this image you have to appreciate these are the curly A lines. Due to distension of anastomeric channels between peripheral and central lymphatics, you have to read about the pathology. Curly's B lines, short horizontal lines situated perpendicularly to the pleural surface at the lung base, which are shown by white arrowheads. See, these are the white arrowheads, and these are the curly B lines. Curly B lines. Short horizontal lines situated perpendicularly to the pleural surface at the lung base due to edema of the interlobular septa. So you have to look at the lung base for B lines, and B for B and B for base, and A lines you have to look from the periphery to the hilar, that is to the hilum, the hilum region of the lung. So hilum region of the lung, periphery to the hilum, curly line A, and at the base B for base and B for B, curly B line, curly C line. Black arrowheads are shown in that figure, and it is reticular opacities at the lung base representing superimposed curly B lines. So these are reticular opacities, and these are the curly C lines. Okay, I hope it is clear. Causes of curly lines, the causes include pulmonary edema, which we see in a very commonly in a day-to-day basis. Pneumoconiosis, rare. About pulmonary edema, you should always keep in mind. So next time you see a patient of pulmonary edema, look for curly lines. Okay. Infections, viral or mycoplasma, lymphangiectasia rare, mitral valve disease, lymphangicarcinomatosis rare, interstitial pulmonary fibrosis rare, lymphatic obstruction, congenital heart disease, sarcoidosis, alveolar cell carcinoma, lymphangiomyomatosis, pulmonary veins occlusive disease. So just keep these conditions in your mind. Pulmonary edema, which is very common pathology we people see, look for curly lines in those x-rays which you see next. causes of an opaque hemithorax. See, this is these are two hemithoraxes. So this is opaque right hemithorax. Technical conditions in which we see due to rotation of the film or scoliosis, we can see opaque hemithorax. Pleural pathology, hydrothorax, this can be fluid. Large effusion, if it is a large effusion, pleural effusion, thickening, mesothelioma, surgical pneumonectomy, thoracoplasty, congenital pulmonary agenesis. Mediastinal cardiomegaly tumors, pulmonary collapse, consolidation and fibrosis, and diaphragmatic hernias. Unilateral hypertranslucency, that is more dark. Comparison alone should reveal any focal or generalized abnormality. Look for the signs of obstructive compensatory emphysema. Look for these signs like splaying of the ribs, separation of the vascular markings, mediastinal displacement, and depression of the hemidiaphragm. We discussed some very important conditions and very important signs. Now let's move on to next heading, that is pleural abnormality. This until now we were talking about lung parenchymal diseases. Now let's see about pleural abnormality. So some common conditions we see: pleural effusion, pneumothorax, and then we see we will be discussing more about pleural effusion and pneumothorax, pleural fibrosis thickening, plaques, calcification, pleural tumors, fibrothorax are just the add-ons to what we commonly see in pleural abnormalities. Pleural effusion, fluid in the pleural cavity, that is pleural effusion. See, if you can see over here, that's where the importance of that costophrenic angle. You can see the costophrenic angle on the right side is clearly visualized, but on the left side, the costophrenic angle, the costophrenic and cardiophrenic angle. See, this is the costophrenic angle. It is blunted, and this is the cardiophrenic angle where it should have been. It is also blunted. So this is seen in pleural effusion. Erect chest X-ray is the commonest appearance. Is an opaque meniscus as costophrenic angle. See, you can see opaque meniscus. If the effusion is very large, the entire hemithorax may be opaque and the heart may be pushed to the normal side. So, pleural effusion pushes the heart and the mediastinum and the trachea to the opposite side or the contralateral side. Let us quickly discuss features on chest X-ray: blunting of the costophrenic angle plus cardiophrenic angle, fluid within the horizontal oblique fissures, meniscus will be seen, and with large volume of effusions, mediastinal shift occurs. Only with large volume effusions, approximately 200 ml are needed to detect an effusion in the frontal film versus 75 for the lateral. So 75 lateral film is more sensitive to look for pleural effusion. Atypical effusion, and just keep in your mind lamellar and loculated effusion. Lamellar effusion, shallow connection between the lung surface and the visual pleura, sometimes sparing the costophrenic angle. And loculated effusion within the fissures. So, and let's move on to the next. So I hope it is clear. Okay, now let's discuss about pneumothorax. Refers to the presence of gas in the pleural space. Open pneumothorax and closed pneumothorax. Air can move in and out of pleural space during the respiration. Open pneumothorax. No movement of air occurs. That is closed pneumothorax. Valvular. Air enters pleural space on inspiration but does not leave on expiration. Okay. When this collection is constantly enlarging with resulting compression of mediastinal structures. So when the collection of gas is constantly enlarging with the resulting compression of the mediastinal structures, it is known as tension pneumothorax. Tension pneumothorax is very important. So what is tension pneumothorax? If the collection of gas is keeping on expanding with the compression of the mediastinal structures, then it is called tension pneumothorax. Deep sulcus sign, very important. This sign refers to the deep collection of intrapleural air. See, pneumothorax. In the costophrenic sulcus, you can see this is the costophrenic sulcus, and Deep collection of intrapleural air is seen here, as seen on the supine chest radiograph. See, this is the deep sulcus sign. Okay, you can see over here also. So visible visceral pleural edge. See, you can see a pleural edge. The arrows are showing a pleural edge. If you can just appreciate, I will just draw for you for some. You can see a visible pleural line sign. No lung markings are seen peripheral. You cannot see any lung markings on the outer side of like in this region. The peripheral space is radiolucent compared to adjacent lung, and lung may completely collapse, and no mediastinal shift unless a tension pneumothorax. So there is a mediastinal shift only in the case of tension pneumothorax. What is hydropneumothorax? Fluid and air in the pleural cavity. Commonest presence of pneumothorax as well as hydrothorax in the pleural space. Concurrent, it is concurrent. Both are present. On an erect chest radiograph, classically seen an air fluid level. See, this we can see an air fluid level over here. This is an air fluid level, and so that's it. Just read about this Lao design and various named signs which I described, and try to look at more and more x-rays. Try to interpret them using the format I gave you in the previous session, and keep reading. This is just very basic information, and the most important abnormalities I have discussed, and you have to keep on reading, and I hope you will master the art of reading a chest x-ray, and so all the best. Thank you. Take care.